Well, thank you, and thanks to all of our panelists for a very stimulating discussion. I'd like to turn it over now to the committee first for questions. We have about 15 minutes before we'll turn to the third panel. So I'll take the questions as they appear. So we'll start with Laura, Dr. Gitlin.
Thank you each for presenting very novel and creative and important approaches. My question is more directed to you, Susan, but I think the other panelists may have some input as well. I wanted to return to your comment about the importance, your emphasis on the importance of culture change, and you had outlined a couple of strategies for that, and I'm wondering if you saw a role, I mean, and you really directed your remarks primarily to those in the field, and what about the students? And I was wondering if you had any thoughts about how accreditation bodies could impact the current health profession education, and in what ways, in specific ways, to demand competencies that would then translate into culture change in actual practice.
Well, that's a big task. It's very worth having meetings with them. That isn't a group that I have yet approached. I'll just take nursing as an example. And we need to do that. I've been talking to individuals that might be more open, like the Deans and Directors group that works a lot in this field. Will you be willing to come to like a round table around this? So we do want to go there. And I do think it's, so much of, again, I'm going to stick to nursing education for now, is so acute care focused even to this day that it tends to be more clinical tasks than it does on teaching. It used to be much more around teaching. So we have to return to that, and that has to be part of the NCLEX exams that the students take. But it's also about what faculty do. There was one dissertation that a faculty member shared with me that she has instituted in her own teaching that I think should be the role model for what everyone does, not just nursing. And that is, she calls it, I talk it out. So as she goes, a student's there, but it could be a nurse not with a student there, she says what she's doing. So I am inserting this tube, I'm putting this in now. When you go home, this is what you're gonna need to do. Even if the person, she does it even if the person's unconscious. She has routinized this, talking out what she's doing. And she said clinically it's important because sometimes she doesn't know why she's doing it. So she has to really think, what is the evidence behind it? That's part of culture change too. It's professional standards of practice. So I do think that it's possible that we should find out more of these more innovative techniques and start sharing them. So that's on my list of to-dos also.
What I would do is have patients and or caregivers on the curriculum developers in all these schools. Just throw them in there and tell them that they're going to be part of it. That'll change the culture.
Thank you. Dr. Saja?
Hi, thanks to all the speakers for your presentations. I have a question for Susan, but any of the other panelists, of course, can chime in. A theme that seems to have come up really the whole morning is caregivers' need for training, guidance, and information. And I'm wondering if you could talk about some models or strategies on how to provide this anticipatory guidance given the heterogeneous needs of caregivers and the dynamic nature of the caregiver experience. How do we get training beyond discharge, hospital discharge for families? I know you you alluded to some tools such as videos that perhaps can provide this kind of training, but then an issue becomes how do you make caregivers aware of these videos and how to access those videos and disseminate the tools once they become available.
I want to acknowledge Nurses Improving Care for Health System Elders that Terry knows very well at NYU. I really started this, and pardon me? At the Beth Israel, there you go. And Rita Chula, who is in the audience, has been a key partner in doing this work. And we started with them a system known as Ask Me Too. And it's Ask Me Too, T-O-O, but it's also Ask Me Two questions. And the nurses are now in these the pilots, it's going to be published very soon, and then we're going to expand this, is how are you doing and what do you need? So the nurses, and this goes on the chart, on the interprofessional chart, they're really changing the culture in those 5 pilot sites that we're doing it. The videos are, it's going to be a big focus this year at ARP. We are using internal funds and external funds. Currently, Pfizer has stepped up to the plate, but we hope more to have a consortium around this, including home care, other professionals, really trying to help everyone. We don't want to own everything. We want to spur a culture change. And believe me, as we put them on our website, I see Nancy Thompson's in our audience too in the communications part, media communications of ARP. Believe me, this will be pushed out. And we invite everyone, Kathy Kelly's been part of this, Carol Levine, many others, to really try to get at. We want multicultural. We don't want videos that are just in the hospital. We don't want them in beautiful bathrooms. You know, we want them real. We're really, you know, it shows what people are living with and invite people into critiquing them, telling us if there are better ways to do it. We just want to start and get moving on this so that there are some tools out there to play with.
In the future, this will be electronically delivered to patients, families, caregivers, and again, at least my hypothesis is that the hub of the wheel will be the record, so that if you have a patient with Alzheimer's whom you're managing, the doctor or the nurse or the institution will push a button and these videos will be there at home for you to learn about and to understand. That's what's coming. How quickly, I don't know. Pfizer has a lot of money. Tell them to pay for it.
I think just to add that I think we have to be sensitive to our caregivers in terms of their learning styles as well as their language, as well as their culture. And you know, some people like to read books, like the 36-Hour Day. It's a great resource, but some people don't want to read something that long and may want to have more focused materials. And in terms of specifically talking about focusing materials, if you give them a stack of materials that they feel are not pertinent to them, if they have Lewy body dementia and then they get a bunch of materials on Alzheimer's and other things, and you expect them to sort through that, it ain't going to happen. So it has to be tailored to them, not only in terms of their learning styles and preferences, but also as much as possible the type of dementia or type of disease that they're dealing with for their loved one.
Thank you. This is such a great panel, and I want to make a quick comment and then ask a question. And the comment relates to our program, Nurses Improving Care, the Health System Elderly, which has been commented on twice, is in over 600 hospitals in the country, funded by the John A. Hartford Foundation, which I want to underscore. The question I have is, a couple of you alluded to lower cost, Dr. Tan, you in particular, and I'm interested, Tom, in whether or not you have any cost metrics on the horizon for your work. In the committee, I think about carrots and sticks, and I'm actually pretty interested in sticks these days because, you know, we're talking a good game for too long. And so here, if Open Note was a never event, if you failed to use it and were a never event, we might see some traction.
I like that.
Yeah, thanks.
Yeah, my daughter began with taking off the wrong hip, so we'll go to never events. Yeah.
Yeah.
We have inferences about, if you don't mention quality, high value care, now you're shot, right? So you have to ask that question. We have anecdotes and inferences, but no data. The patient who says, I read my note, Tom, I did everything we discussed, I'm feeling fine, I don't need to come to see you next time. You multiply that missed visit by a few million, you're talking about real dollars. We think there are enormous patient safety elements. I didn't have time to talk about it, but we had the lawyer who had to leave talking about it. We're running a program now in which patients are identifying errors, trying to pick them up and make a difference. We have inferences that drug adherence is going to be better. Anna, sitting on your right, said, you know, I asked her, how are you going to get your little company to mandate Open Note? She said, give me some outcome facts, not just statements from patients. We don't believe patients. We have to have some real facts. That was the implication, Anna. So we will we'll try and get some facts. We have to study it. We have to learn about it. We have to have large samples. But I'm actually quite bullish on the fact that this will work. John Dara, who runs Open Notes at Geisinger and who's a hard ass, basically thinks that this kind of approach, this transparency in care, could offload about a third of the doctor's work. So we're now into our notes. We're already bored with Open Notes. Our notes is when patients, caregivers begin to contribute to the note, co-generate them with us, co-sign them with us, really put skin in the game, as you have to say these days, become more engaged by that, and we think that over time that will produce higher value care.
I could just comment on for the dementia care program, we've shown that we increase quality, we increase patient and caregiver satisfaction. Lowering costs, I think, is a much more difficult thing to show, especially for a disease like dementia, which is progressive. You can expect that as the disease progresses, their burden increases, they get sicker. So it's not so easy to compare someone before, let's say a year before or 3 years before they get enrolled to the program, where they are now, because they will increase just because of the fact that the disease is worse.
Can I
and
challenge you on that?
Yeah,
Can
go
I
ahead.
challenge you on that? Depends what you do about it. So if somebody has a new symptom, you can decide not to treat it, and so this triangulation of how a person wants their care delivered and the way that you and I, who are in acute care settings, do what we do. So, it's very interesting, and I'm hoping that we look at it from a variety of ways.
Absolutely. I think by educating patients and expecting them and educating them of the natural course of the disease, that will surely happen. But it is a challenge.
I just want to add that the CARE Act is, I hate to call it a stick, but it is strong
I
policy.
don't mind sticks.
Yeah, I'm just saying, but we're also trying to help spur innovation through it too. But it would be state law, it is state law in 2 states, and that does then give more enforcement authority to not just federal Medicare conditions of participation, but to state laws.
You comment on how you're following those 2 states so they can be like a baseline against others?
Yes, I mean, some are going to, they have to go through regs, they have to go through more of the process, but we will be. And as I said, there's 7 more states in the pipeline and even more behind that.
So Charlie, Alan, Peter, and then Judy.
Thank you all for your very thoughtful remarks. They're very helpful. Dr. Tan, I have a question. Do you have any thoughts or comments on how translatable your model that you're using is to all advanced illness conditions rather than just dementia? What it would take to expand it and translate it?
I think, thank you for that question. I think dementia is probably one of the most challenging, if not the most challenging diseases to care for caregivers, just because it presents not only the medical, but also a psychosocial, it's progressive, and it's very difficult to predict what they're going to need in advance, because patients' dementias could present very different ways. Some people get behavioral problems. Some people are presently demented and don't have such behavioral problems. But in terms of expanding the model or translating the model to other disease conditions, my colleague Dave Rubin actually is doing that for falls. And so with another grant, we're working on training not dementia care managers, but fall care managers, to see if that will, having the similar protocols and education materials, could actually decrease the risk for falls. So I think that's a good question. We don't know if it could be adapted to other conditions, but we hope so.
And then that'll be actually our last question for this panel. Thanks, Jennifer.
Thanks to all of you. Dr. Tan, I appreciate the comprehensive nature of your program, especially your outreach to partnering with community agencies, which I think is a huge strength in the work you're doing. It does bring up a concern in dissemination if you move your model program, which again, I applaud, into a typical fee-for-service arena in a Medicare setting. Do you have any estimates of what percentage of what you're currently doing in your model program could be covered or would be covered in a typical Medicare fee-for-service environment?
So we are a Medicare fee-for-service environment, but we are funded by the CMMI. So the challenge with this is that it's the time spent by the dementia care managers and nurse practitioners are not covered currently by Medicare. They're not billable hours. The electronic communications through the electronic medical records, the numerous phone calls that happens. You know, we know, at least, I don't know if we'll be able to show it, but we know that that actually makes a difference in terms of utilization and reducing unnecessary ER visits and reducing hospitalization, because we also assist with transitions in care. But whether that will translate to a billable Medicare benefit in the future is what we hope. It's not yet there. So right now we are exploring many different models to sustain this program, which is working well, at least for our health system. But translating this more broadly, I think, will require some policy changes.
Madam Chairman, may I just clarify? So as I understand, as this moves forward without changes, everything that you propose except a physician visit is not currently reimbursable.
That's correct. And just to clarify, they actually don't see the physician.
I'm sorry, the provider or
Right, so they bill for the visit, the nurse practitioner bills for the
Yes.
visit, but that's about it. The rest is not billable.
Okay, thank you very much.
As we shift to our next panel, let's thank this panel.